Okay, hi everyone. Good to see you. Welcome to Spring Quarter. So we're very excited. We have an in-person speaker for our first seminar, which is amazing. So we have Dr. Courtney Lyles, who's the director of the UCD Center for Healthcare Research and Policy, or CHPR, and the PI of the UC Davis Clinical and Translational Center, or the CTSC. Courtney is a trained health services researcher and has expertise in health equity, digital health informatics, and implementation science. Her research portfolio designs and evaluates new programs and platforms to support patients and families, as well as clinical workflows, with an emphasis on participant and community engaged methods and chronic disease prevention and treatment. And Dr. Lyles and I recently served on a grants talk for the Center for Poverty and Inequality Research this year, and that was really fun because it was the timing around when all like the funding cuts were happening. So trying to spin that was a challenge, but it was fun to do it with you.
Yeah, super fun.
So thank you so much for being here. I'll let you take it away.
I really, truly appreciate it. I'm going to keep my camera on, even though it's a weird angle for people who are joining online. So I'm a public health researcher. I thought I would talk today about digital health interventions that I work on. That's my area of expertise. They're not specific to nutrition. This one I'm going to talk about today is a little bit more physical activity focused, but I think a lot of the applications and sort of the principles apply for any health behavior type of intervention. So I thought you might be interested in that. So with that, I will get started. So I thought I would give a little bit of background. I like to ground sort of how I approach digital health research before I go in. And then I'm going to do one really just large example of a trial that we recently read. And maybe if I have time, touch on two other things that you might be interested in. And I really do want questions and discussion. So I'm trying to finish a little early. So please do gather your questions for me because I want to hear them. Okay. So this is something that I like to show. You might have seen it before, but it's a pictograph that I think has been really helpful for me. It's from the Robert Wood Johnson Foundation, which is a health philanthropy organization. And it's a little old. They actually made a new one in case you're interested in checking out their pictographs. They're actually pretty cool. But it's trying to depict the difference between equality and equity. And the reason I keep coming back to this is the reason sort of that I came to digital health. So I'm more of a health equity researcher. I've been working on that for like 20 some years of my career. And the reason I want to work on technology is because the more and more I thought about the types of interventions that I wanted to do, I wanted to be able to do this type of personalization. And I feel like technology has the ability to meet people where they are, to understand their preferences, their needs, or where their starting places are, and can be customized to who they are and what they're looking for. So that's the vision that I have when I say equity, is trying to really tailor and personalize to make up for gaps that people face in their everyday life. And then, so I've thought about this a lot. Shocker, I'm an academic, I think about things too much. And so in case you're interested in this, I've written a couple things about it. And I thought, because this is sort of the ground of how I've approached some of these trials, is I've really tried to push my research across levels of influence. So this is just sort of like a socio-ecological way of thinking about the world. And when I center of digital health equity, I've just thought a lot about what that means. So what that means for individual participants in our healthcare system or in our studies at the core, but sort of where they live, which communities they interact with, what kind of services do they receive, and then what are the policy levers that impact them that would allow them to either engage easily with what we're offering or be a barrier to what they engage in. So I won't belabor all of this, but just this idea that our research or our programs, can we stretch across levels of influence to make sure that if we're focused on the individual at the center, which most of our work is, that we're taking into account what kinds of devices, what kinds of services and community-based organizations people are interacting with to increase the uptake and use of whatever we're trying to design. So I thought I'd give a few stats on that because it affects why we do some of the interventions the way we do, which is digital health equity is a really interesting topic. The one that I think is really interesting that some people know about, but I think some people haven't thought about, is smartphones. So this is national data. It's a little old, but it still holds true even in the most recent Pew data. This is a national research organization called Pew Research, and they interview and survey, thousands of Americans. And this graph is sort of the proportion of Americans that use their smartphone only. So they do not have broadband at home. They use their smartphone most often their cell plan at home or free Wi-Fi in public places. And you can see here the income is sort of the line graphs here. It's flipped, it's inverse by income. So the lowest income Americans, those making less than $30,000 a year, are the most likely to be smartphone dependent with no broadband at home. That makes obvious sense, but the reason it comes up a lot in our research is I work in healthcare systems, and we talk a lot about video visits and things that patients can take up, and whether or not a patient can use something like a video visit if they're smartphone dependent on a limited data plan for their total amount of bandwidth per month is just a very different decision than for individuals like me who have broadband at home and I have, very large amount of data that I can use a month. So this is sort of a structural factor that comes up for patients who enter our healthcare system because they have different ways that they're interacting with their phones. To zoom down one more level, at the intervention level, we think a lot about that tailoring. So going back to that picture that I showed you, one of the most concrete examples of tailoring for me is language. Why can't our technological interventions be accessible in all the languages that our communities and our patients, in my case, interact with? That's possible, it's technologically possible, but yet you see on the app market and almost many RCTs, lots of things happening in the world that we're actually mostly doing English only interventions. So we spend a lot of time thinking about language adaptation and doing all of our studies in at least 2 languages, and sometimes we've been trying to do at least 3. So that's another barrier that people face that I think technology could help us solve. And then I can't be remiss to talk about this without thinking about skills. So that was sort of at the center of my graph that I showed. People have to be interested in using technology, have the skills to be able to use what we offer them. And yet there's not a lot of national data on digital skills. It's not like that Pew research that I just showed you. There's no good data that I know of that says like, what is the proportion of Americans who feel like they have basic digital skills? But in San Francisco, where I used to live, they have this wonderful survey. And so this is data just from San Francisco, but I think it's a nice sort of microcosm of the world. San Francisco, very tech-connected city, right? If you think about it, you would think everybody in San Francisco has digital skills and uses the internet. But when they actually added a question on the survey about skills, and so they said, who doesn't have home internet, which is the same question that I showed you above in the Pew survey, but they added a question about, can you do basic tasks online? And they defined it. They said, can you send an email on your own? Do you text message? Do you search for things through a web browser? When I say basic, I mean very basic skills. And then they subset that data by subpopulations in San Francisco. So the proportion of respondents who said they had no home internet and they did not answer that they had any of those basic skills was much higher among lower income San Franciscans, non-English speaking San Franciscans, and older adults. So the reason I show this is that it's not a niche thing. It's not like a small group of people who are left out of the digital divide. It's really at every level, whether how they use their phone, whether or not they have broadband at home, whether or not they have the skills. It trickles down at all levels that presents barriers for people for accessing intervention. So I think a lot about skills and the types of things that we design. And then I'm not going to go through these data, but whenever I say, oh, there's difference in skills, I want to be really clear that skills is not the same thing as interest. So across every single study, I've asked patients across, 15 studies, maybe more, are they interested in using? So this is, do they want to use video visits at the peak of the pandemic? We went to all patients in San Francisco. We asked them for primary care as they got ready for their visit. Do you want to try video visits? Have you ever done it before? And this is just to show you across every age group, across every language, across every racial ethnic group, there was really high interest in trying video visits, even for people who didn't have the skills or didn't have home internet, right? So the interest is high. And my premise is here, we have not designed it to meet people's skills or to meet their interests. We have a huge gap in that area. So how are we doing interventions that meets people where they are and is tailored for them to give them a tool when they're interested in using it? Okay, so that's sort of to get you primed, get you some national data and some other data from other studies. But now I'm going to talk just about one example that I thought you might be interested in. This is San Francisco General Hospital. This is a picture of it, very historic building. It's the public healthcare system for the city and county of San Francisco. It's where this study was completed. And what we had tried to do was design a physical activity intervention. So I thought I would talk through both the design of that intervention and then the randomized clinical trial that we ran. So the study is called Diamante. This is a picture of a lot of people who worked on the Diamante study with us. It is done with my co-collaborator and co-PI, Dr. Adrian Aguilera, showed here on the left-hand side. He's at UC Berkeley. And we were co-PIs of this study, and it started a while ago. It's kind of funny to think about where technology has gone since when we started this study. We started the study in 2018, and the study concluded recruitment in 2022. And you can see AI and machine learning have come a long way since 2022, but just keep that in your mind. And the goal was to increase physical activity among English and Spanish speakers, and the patients had to have both depression and diabetes. That was sort of the goal of the Diamante study. So we thought a lot about this, and we thought a lot about what were we trying to improve and how were we trying to improve people's health in everyday life. And we chose physical activity for a variety of reasons, but the main one was physical activity is a required and not required, a recommended and important treatment for both diabetes and depression. And yet we treat them very separately in the healthcare system, right? We silo out our mental health support from our physical health support in a lot of ways. And we said, well, why wouldn't we try to recruit individuals who have both of these conditions and try to work on physical activity so that they can improve their mood and their mental state and also improve their blood sugar control. In case you don't know this, they're actually very, very common together. So it's estimated that up to 40 to 50% of patients with diabetes also have depressive symptoms. And it's really hard to manage your manage your diabetes rather, if you have depressive symptoms, right? It's going to be a lower priority on your list to take your medicines, to be able to be physically active. So thinking about them holistically was sort of the premise of this study. And physical activity has been an evidence-based intervention for both. And then the next premise of the study was text messaging. Of course, I'm a digital researcher, but we spent a lot of time making sure that text messaging was sort of the right modality to improve physical activity. And I could talk about this all day, but there's actually a pretty robust literature on text messaging, specifically text messaging to improve physical activity, in a meta-analysis, many others. And we centered in on text messaging. We actually did a lot of design work that I'll talk about in a minute, but text messaging, thinking back to what I just showed you all, easy to access, simple to use, timely, reaches people where they are in a moment in time, and still very widespread. So when I thought back to our smartphone data and sort of those, it's not this extra click through to an app, other downloads needed, right? The most simple modality we can use that has wide accessibility and also impact for people. And then the last thing we do, which I'm sure you're going to be really interested to talk to me about, is we use machine learning. So the other thing we thought about a lot when we thought about text messaging was text messaging can be very static, right? It can be like send everybody a text message about doing physical activity. That's been shown to be really effective. But getting back to my personalization comment that I started with, how about we personalize the text messages? How about we take into account who the person is, what kind of physical activity they've been doing recently, so that we tailor the text message content based to each person in the study and see whether or not this adaptive or personalized messaging is better than just static text messaging. That was the third part that we were looking at in this study. So I'm going to come back to that. I'm sure you have so many questions that people always are asking me about my algorithms. I'm curious if you guys want to know about it. We partnered with the computer scientists, full disclosure on that. But before we even got there, of course, we spent a lot of time in design. So I thought for this audience, I would just mention how much design work we did with our patients and our community members. We spent over a year, probably a year and a half, in 3 phases of design. We used a lot of really common design methods. We used more qualitative methods, open-ended interviews, really talk to people about their physical activity habits, sort of their text messaging preferences, just their care at the hospital, all sorts of different things. And then we brought them back and did, I would call, more closed-ended kind of sessions, which are common in design. So we had them rank and sort example messages. We had them storyboard or brainstorm how this intervention might look like. They helped us iterate and come up with the best message content and the best timing of the messages that we might want to send to them. And then we tested these online with Amazon MTurk. So we went through and tested it. There's this, if you don't know what MTurk is, it's sort of a national database of people who can sign up to do small sort of studies, micro studies online. So we tested the message on MTurk And then we also did real world piloting. So then we got everything ready to go. And of course, then we tested it with real patients to make sure that it still mattered to them, that when they said they wanted a text message at noon, then when we tried it out, that they still liked getting the text messages at noon. So we did it across many different phases. I don't think I have as much time to talk about this, but I'm also really interested in, can people engage in these kind of design methods in the same way? So if you're interested in that, please come and find me, because I was really interested in, a lot of the times, if you do human-centered design methods, or you think about companies like IDEO and these really amazing things, they have all these, I would call them generative design activities. They have people brainstorm, they have them come up with new ideas, they have them iterate. And it felt a little bit like a formal education kind of thing. And so I was really interested, do different types of patients engage in those design methods differently? And they do. It's only 20 people, it's a small sample. We do small, like 6 to 7 people in a group multiple times to get their input. But you can see here, there's a real big difference in our patients and sort of how many times they had unique ideas, that they were able to provide extensive feedback. And I think that has to do with how the power dynamics in a design session and sort of how they show up. So I have a whole nother body of research where I'm really interested in, how can we make sure design methods are inclusive and make sure everybody has an opportunity to give us input on what they're looking to see in the intervention. So I thought you might be interested in seeing that. Okay, but back to the study. So then we did all this design. Then we ran the study, right? So then we put up the study, we started recruiting, and then the pandemic hit. So we launched the study in January 2020. Great time to launch a randomized trial. It was a 3-arm study. I'll show you what that looked like in a minute, because we had a control group in addition to testing these random versus adaptive messaging that we were really focused on. And then we had to expand recruitment. So we did do clinic-based recruitment at San Francisco Health Network, which is where San Francisco General is, but we added online recruitment through Facebook, Google, and Craigslist ads, because it was impossible to meet our recruitment goals in the middle of a pandemic. I won't spend as much time talking about that, but I'm happy to talk about what online recruitment looked like. And then, of course, all English and Spanish-speaking patients with diabetes and depression who didn't have mobility restrictions, because it was a physical activity intervention, were eligible to participate. We randomized 1-to-1-to-1, so equal in all 3 arms. It was stratified for English and Spanish to make sure those were balanced. And then it was a 6-month intervention where everyone got a daily text messages. And our primary outcome was total change in steps by arm. So I touched on this, but to come back to the algorithm and the intervention a little bit more in depth, the control group didn't receive physical activity messages, right? So that group only received a weekly mood message to check in on their mood and their mental health. So they went through the study, the 6 months, they got a message, I think every Saturday, that asked them to rate their mood from 1 to 9. That's really all they got. And then, of course, we wanted to test the messages against themselves. So we challenged ourselves to have 2 sort of active control arms, or active intervention arms, rather. The one group had the same bank of text messages that we spent all that time designing and iterating, and all they got every day was just a randomly selected message from our text message bank. And they got that every day for the 6 months. And then the adaptive arm is the arm that received the reinforcement learning selected message. And the reinforcement learning algorithm went in and predicted which message would be best for that person every single day. So then what did that look like? So just the reinforcement learning arm, just the adaptive arm, this is sort of what it looks like. Every time a patient was enrolled or a participant was enrolled, they set up their physical activity goal. So that's important on the left. So we helped them download this app. They didn't have to interact with the app. There was nothing they did on the app, but the app sort of helped collect and integrate all their physical activity data from the pedometer in their smartphone. We didn't ask them to wear a wearable. We didn't ask them to do anything different in their everyday life. All we asked them to do is have this app on their phone. And they gave us their goal, and we really let them choose their goal. We didn't say you have to do 10,000 steps. That would be really unrealistic for a lot of the people in the study. We really looked at what their pedometer said on their phone over the last week. We talked to them about what would a reasonable goal be for them. Just want to go 25% higher, it would be this number of steps, and we helped them set a personalized goal. And then as they entered the study, in the middle of this graph, we had a lot of information about them. So on the bottom left, on the feedback and the contextual variables, we knew a lot of information about each person. So on the very bottom, we knew everything they gave us on the baseline survey. We knew their age and their gender and which language they were participating in the study. And then as they started to move forward, we also started to know a lot of time varying information about them. What message we had sent to them yesterday, how many steps did they do yesterday, what was the slope of their physical activity in the past week. And so we used all that new information that we gathered from them, mostly in the physical activity range, because that's what we had collected on the app, to feed into our algorithm. So we had all this static information about them, and then we had all this like new physical activity related information about them. And what the algorithm did at the top is it actually ran 3 separate algorithms every night. And then it went in and it chose 3 things for each person. It chose which feedback type of message to send that person, which motivational message to send this person, and which time of day to send the message. So feedback was just how many steps they were doing. We wanted, that's an evidence-based intervention to give people feedback. You walked X number of steps, you met your goal for your steps, or you didn't meet your goal for your steps. It was related to their step count. Motivation were theory-informed messages about knowledge and skills, emotional, self-efficacy for doing physical activity, or advice and tips for how to do physical activity. Had different categories, theory-informed categories that it would select from. And then time of day is pretty obvious, but the algorithm actually chose, did the person walk more when we sent a message in the morning versus in the late morning, early afternoon, or evening? So it's between 8 a.m. and 8 p.m. And so it would optimize on the time of day. And then it would go through and choose each one of those and send them messages the next day. That's in essence how the reinforcement. Obviously, AI has come a long, long way from when we did the study till now, but I do think this idea of reinforcement learning algorithm has a lot of use because it's very controlled and it's very specific to predicting increase in steps per person in a study. Okay, and then the last slide about this is this is what it looked like. So, because everyone's like, well, what does that seem? So they get 2 messages in sequence. The first is their feedback message, and the second is their motivation message, and then it varies the time, right? So those are the 3 things that's predicting. So on the left, you can see it got a more goal-oriented feedback message. You walked less than your goal. And then they got a more educational type of message. Being active helps you manage your other health conditions, which is one of the things that many participants said, like, I have a lot of things going on. I need support for all of my health conditions. And then on the right, it gave a more numerical step feedback. So it gave you your actual step count, and it gave you a great job if you were above your goal, or you can do better kind of encouragement if you were less than your goal. And then this one got a more mental health, motivational type of message. There's a typo in this, so ignore that. That's our testing environment. But like thinking about your feelings. So in depressive symptoms, when you're managing depressive symptoms, behavioral awareness and activation helps you sort of change your mood and be more aware. So this one was like, start thinking about and noticing your mood, noticing how that affects those around you. So this is all they received is essentially 2 text messages, and then algorithms all working in the back in the back to pick what they got. Okay, and then did it work? So this is the consort diagram from the randomized trial. We assessed a lot of people for eligibility, but there was 195 people randomized in our trial. This is what it looked like. There's actually only 168 had usable data. There was a lot of interesting data issues. I think mostly from bots that enrolled in our online study. So we went through and removed a number of people that we thought were real individuals who enrolled in the study, which I'm happy to talk to you about. But we still had 168 of usable data among our randomized sample. And this is just to show you, still very diverse, mostly female, but a quarter of the participants completed the entire intervention in Spanish, really diverse with respect to race, ethnicity, really matches sort of the San Francisco general type of population, even though we expanded to online recruitment. And then really diverse with respect to education, which again, maybe not quite as the spread I would see just amongst our San Francisco general population, but still a pretty, it wasn't all college graduate individuals who we found on Facebook, for example. It's pretty good spread. And then one of the other things people always ask me, well, did the algorithm work? Like, how do you know it worked? There's a lot more I could show you about this, but really what you're looking at is, did the proportion of the types of messages in our banks of messages change between that random arm and the adaptive arm? And you can see it did change for almost all of the message types. So for the feedback messages, it was an upweighting of steps walked yesterday. So there's more people who got that step summary kind of message in the adaptive arm than in the random arm, for example. And then down in the motivational messages, all of them were different, but to give you an idea that these capability focused messages that are a little bit more educational were actually upweighted in the adaptive arm. which I actually would have thought it went the other way, but more people got sort of these physical and psychological benefit type of messages over time. And then lastly, did the trial work? I love how apparently I was a skeptic. I was like, I don't know if this is going to work, but it worked. And I still have been thinking a lot about this and sort of what to do next from it. But the adaptive group is the black bar here, and then the other two arms are shown in purple and red. And you can see that the adaptive group, those that got those personalized messages, had a 19% increase in their step count, which was estimated to be 606 steps higher over the course of the intervention than the other two groups. I would say that's a moderately clinically, it's not like a huge step increase, but it's statistically significant and pretty moderate from like a clinical significance. A lot of these people had pretty low step counts at baseline. So 606 is a pretty good increase. So yeah, that was the main thing I wanted to cover today, and I'll see if I can get through these other two, but really just taking that sort of digital health equity frame that I showed you at the beginning and showing you what that looks like in a real world intervention and how to blend sort of classic randomized trial methods with thinking about the real world implications of an intervention that works for the patient population that we were, that made sense to them and wasn't just taking off people who had high digital skills and giving them a physical activity intervention, but really making sure it worked for the broadest suite of patients, because that's who we're designing with, to manage the physical activity goals. And just this idea that reinforcement learning seems to work. It seems to work in personalizing messages. It definitely did change the message composition in our sample, and it actually worked better, I didn't show you this analysis, for the San Francisco general population than it did for the online population. And I think that's because the messages were designed in that population and tested in that population, and then we expanded to a broader sample. So I think some people would say, oh, no, it probably was your online sample. And I was like, no, actually the highest the highest step count increases were actually among the sample of patients, Medicaid patients who we worked with to design the study from the outset. And these patients, just to come back to where I started, are almost never included in machine learning or AI research. Patients, I didn't show you I should have talked more about San Francisco General. San Francisco General is a healthcare system that doesn't even accept commercial insurance. So it's not an insurance type in the entire healthcare setting. It's funded by the city and county of San Francisco through the San Francisco Department of Public Health. So it's patients who are truly, I would say, often left out of academic type of research, and certainly not often AI. I worked there for 13 years. I can say this very certainly without AI type of, maybe we're doing other types of research, but these patients in terms of designing an intervention, testing intervention, and being in a randomized trial, this is not often the case in this type of research. Obviously, we had a lot of challenges with the last one, the RCT protocol during pandemic restrictions, but I think we did a pretty good job despite that. We had some data accuracy issues, like I said, so we had to drop some people. We use real world data, right? We didn't try to optimize wearables or get too rigorous and controlled. We really instead had a much more pragmatic focus of the trial. So that means you have some issues with data accuracy and that bot issue that I suggested. And then we didn't know if people read the message or, it wasn't like we were looking for opens on their phone or responses to the text messages. So we still had a significant effect. So I'd like to underscore that. But, there are some people who could have received these and never read them. But despite that, we had a significant track. So yeah, that's the main one I wanted to talk about. I think I'll just do a couple slides, but I do think I'll have time for questions. So that's sort of a flavor of the kind of things we do. But we don't, I would call ourselves or our study team a really pragmatic primary care researchers. So we touch on all sorts of different things. I love physical activity. We've done hypertension. We've done all sorts of different things. And as we were working through that, one of the things that we kept coming up over and over again is, what about the private sector? So I thought I would touch on that for a minute. Like, you guys are in your academic, ivory tower, developing your own interventions. But I know as a researcher, I'm not going to scale that intervention. Like, I'm not here to make a company and to sell my intervention and to take it to scale. That's actually a skill that I don't have. So we started to think through how we would take our academic knowledge and partner with the private sector. And so I thought you all would be interested to hear that we did start this thing. We actually changed the name to UC Solve Health Tech after I moved here to Davis a couple of years ago. but we partner directly with digital health companies. So we try to say that same kind of knowledge I just showed you in sort of design, implementation, and then even in evaluation to really think through the impact of a technology for patients who are often left out of studies. We took that to the private sector and we published a bunch of things on that. One example that we did that I thought would be relevant because it's also in the diabetes space was we worked with a company called Inquisit Health. And they had done a real world peer-to-peer coaching for diabetes. So they go to health systems and they sell a platform or a service that they can take all of their patients with diabetes and they can manage that panel and use peers, so individuals from the same communities, to coach patients with diabetes to improve their outcomes. So the peer-to-peer is not new, but I would think the scaling of this is new, right? Can your company actually take that model, implement it in a real world health system, and actually have real outcomes? So they hired us to do an evaluation. They implemented this program in Montefiore Health System, which is a safety net health system in New York. And they were like, can we show that we actually had an impact? So we helped look through their data and we tried to explain who they enrolled in their study and what the outcomes were. I could talk about this all day long as well, but just this idea that they did enroll patients who looked like the other patients at Montefiore. They didn't just cherry pick patients from Montefiore that were already healthy or ready to improve their diabetes. These patients had a lot of 3 or more comorbidities. They were 83% non-white, so they looked a lot like the rest of the Montefiore patient population, and they were primarily publicly insured. You can see at the bottom. And then we calculated sort of their overall improvements in A1C. They had overall improvements. We helped them make a control group within the sample, right? Something the company was never going to do. They were just going to publish the pre-post of the A1C. And we were like, no. So we helped them make a control group. We helped them to try to identify how many times people checked in on what they checked in about. So they helped them with social needs. They helped patients with medical needs, with getting medicine. They helped them across a wide variety of tasks. And so we were able to sort of slice and dice that data as an example of how we partner with the company with more of an equity mindset of their intervention. And then the last thing I'll mention, and then I think I'll be done, is that I'm also really interested in organizations. And so if anybody's interested in organizational change, I'd be more than happy to nerd out with you about that. We have a new study happening right now called the CHARMED trial. This is on hypertension, not on diabetes, but it's the same kind of idea on the left-hand side in the patient intervention that we're adding text messaging, because we're doing a lot of text messaging work, to patients to support them with their hypertension at home and checking their blood pressures at home. But we added a clinic level intervention. So this is a factorial design embedded in care where all 25 primary care clinics get an intervention first. They get either one-time training on hypertension management or ongoing practice facilitation where they partner with a coach on how they can improve their workflows in the clinic to support patients at home, how they can look at home readings and make actionable changes for patients in real time, and just what they can do in a resource-limited safety net clinic to make a dent in home blood pressure monitoring. And then the patient intervention is embedded within that clinic intervention. So there's 25 clinics, 12 are in the low intensity arm and 13 are in the high intensity arm. And then we're recruiting about 100 patients. So 2,500 patients in total across all 25 clinics across California. So I've learned a lot. The PCORI funded study, I've learned a lot about that. And it's the same idea from Diamante, which is why I thought I would show it today, of this patient intervention, but sort of blowing out how that looks in the context of the service delivery, which is another ring of influence that I showed you at the beginning. How can we think about how to support patients, but also how to support busy and under-resourced primary care teams to really support patients at home, which is always a challenge. So this is another study that we're running. And I feel very proud. We're more than halfway through. We have 1,600 patients recruited. And yeah, it's all the study team. Can't take credit for that myself. Okay. So that's a little bit about us and our research. There's obviously many, many people who work on these studies. I showed you the Diamante team, but there's study teams for all of those slides that I just showed you. As I leave and as you're thinking about questions for me, I just wanted to leave you all with this idea that even a lowly researcher like me really can think about multi-level influences, right? We have control. I did a simple intervention for patients, but I thought about what kind of phones they had and kind of, what kind of text messaging content they want, just thinking about those other spheres, because the more aware we are of where they live and how they use technology, the better our interventions can be. So just having us think again about broader context and what we're doing. That's my main thing I want to leave you with is all of us can be thinking at multiple levels of influence if we're, if we partner correctly and we think hard about what we're trying to achieve and what the right outcomes are for what we're trying to work on. And that all of this requires engagement. So I talked a lot about patients and communities and our design, but we also partner deeply with the clinical care teams who are delivering the care and what their pain points are and sort of what they see every day. We spend a lot of time thinking about and then we partner with the private sector, like I mentioned. So a lot of our work, and I think a lot of the things that I talk to students about over and over again is the same kind of methods that I learned about community-based participatory research. I use that I use that when I'm talking to clinicians and nurses, and I use those when I'm talking to, what are your goals? What are your priorities? How can I use my research to partner with you so that we're on the same team to answer the same questions? And I think that's a really helpful lesson as you think about your career. Is who are my stakeholders? They can be broad, they can be all sorts of different communities, and how can I listen to them and then really invest in those relationships over time? So those are the things I wanted to leave you with. Yeah.
So we have about a little less than 15 minutes for questions.
Yeah,
I know we have a question that came through, but let's get one from the room first. Sabrina.
Yeah, thank you. Very exciting intervention. I have actually two questions.
Yes.
So my first question is about when computing the steps. So does it depend on whether the persons carry the phone with them? Because I realize if I don't use my watch, they don't really count my steps. Do you have any measure, for example, to exclude some outliers of the steps, like this just too small amount of steps, so it's just not reliable?
We thought about that so much, and being a study. What we ended up doing, which I think was pretty successful, is we reminded people to carry that. So when we enrolled them, we talked a lot about how we were measuring steps, and then we reminded them to carry their phones with them when they took walks. And then I think they got a couple of messages about that during the study. So like some of those bank messages that I mentioned had something in there about, remember to take your phone with you if you're taking a walk. It's not perfect by any means. But again, splitting the difference between people having a wearable, not knowing how to use a wearable, losing the wearables, we decided that their phone was the thing that was the most consistent, and we would try our best to use that. And we decided that the error in that would hopefully be consistent across people, right? So we're looking for change in steps. And so if you're not likely to take your phone with you all the time, you still got what you had at baseline and what you had at the end. And that might not be completely accurate, but it was still a reflection of, did you walk more? So that was kind of the choice and the trade-off that we made. Is that helpful?
Yeah, thank you. And then I have another question about online recruitment and learning bots. It reminds me, so we did have an intervention in Indonesia, my fun project. We used application, but we didn't really meet the participants in person. So I'm curious, how do you do the online recruitment, do the informed consent, and also excluding the bots? How do you detect that?
So we had a multi-step process, and then we did some exclusion after the fact for the bots, like you saw from the 195 to the 168. In the pre-steps, we had an online form, and this is pandemic, so we certainly couldn't bring them in person. So we had an online form where they had to self-designate their eligibility, and then it took them to the training page, if I'm remembering correctly, and then they had to do the online consent, and so there was so if a bot was going to do that, it would have to have learned, it had to go to multiple websites. It wasn't like all in one. So we thought through that carefully and they had to reply back to us at an email address. So then they had to give us their email address, they had to do all those steps, consent, and then they had to reply back to us at the email address just to make sure we had contact information for them and that we could follow up with them. So that we thought that would be good. Many people dropped out between the time they had started the eligibility and then the time they had, so there was definitely people who didn't make it through all those steps, which I think was helpful. But then at the post stage, when we looked at the data, there were a lot of just nonsensical data. One thing we did, we looked at IP address. If there was one IP address that was trying to sign up many times, we got rid of that person. We looked at, what was the other big one that we found? The IP address, a country of origin. We started to look through because we had only placed ads in the US. So we started to exclude people out with IP addresses outside of the US, or at least look really closely at it, stuff like that. And so a big proportion of that was them. I'm trying to think, it's been a year or two since we did that. And then there were people who, I mean, it just was wrong. I mean, 50,000 steps in a day, or just something that just didn't seem feasible to us. So we did the a priori. We, of course, we looked at like the total averages, and we made some decisions about what we would cut and not cut from the sample. So things like that.
Thank you.
Yeah.
We have some questions that are coming through the
Of
chat.
course.
So Najim asks, is the Diamante text message algorithm something available for researchers in the UC system for new physical exercise clinical trials and other populations? So is that algorithm available?
Yes, you can contact me. We created it open source. I don't think the code is posted publicly in GitHub, but we have it, and I'd be more than happy to share it with anybody. We used another algorithm from Microsoft Research, and a collaborator, he created an older algorithm I didn't mention, and then we tailored it and adapted it further. So yes, totally. We have a Creative Commons license that we attach to it. So I'd be happy to share with you. And going back to my public partnerships, that's the vision, right? Is to share with more people.
And then Hillary asks, they may have missed, they wanted to know who funded the Diamante
Oh, yes, I
study.
didn't say. It's a funding agency called the Agency for Healthcare Research and Quality, AHRQ. It's sort of like a sister institution to NIH. It's under siege in the current political environment. They've had no grants going out in the last year. So it's really sad. It's a very small, it's an R01. It's essentially like an NIH institute, but it's a very small sister institution that likes to fund health services, you know, these multi-level type of studies, quality of care, those types of things. So it's a really cool agency. If you've never heard of it before, but it's been having some trouble in this current political climate. Yeah.
I had a question, since your timeline started at the beginning of the pandemic and then it went a little bit later.
Yeah.
How did that impact your study? Did
Yeah.
you have to go out further? How did you account for periods where people were in lockdown and they might not be getting as much steps, or people just didn't know it was safe to be outside? Like, how did that factor in?
We didn't have anything. Well, what first happened was very few people enrolled in January and February. You know, we had just gotten going. So I think we had like 30 people or 25 people. We had just gotten it all running. Those people got the original intervention. You know, they had been recruited. And then there was, like, as you all know, in the public health emergency time point, there was sort of a moratorium on research. So then we didn't recruit. So then we didn't recruit between March, whatever, 10th or something, and probably until the fall of 2020, we took an entire pause. So all the people who were in it, we let continue, of course. They were just getting text messages. But in that time, we actually, which I didn't talk about at all, we actually went back to our bank of messages and we read every single message and we made sure it made sense for the pandemic. So we actually changed some messages. We talked about, we gave a few more ideas about exercising in their own apartment or in space, taking steps while you're on the cell phone, like walking in circles around your home. We changed a lot of them. We tailored them. We just spent a lot of time doing that now that I think about it. And so we made sure that the bank was better and we iterated on that. My colleague, Adrienne Aguilera, actually launched an entirely community-based mental health trial for improving mood during the pandemic called Mood Text. If you want to check that out, it's online, where he was just trying to help people with their mental health during the pandemic. And so we started doing that because we had a lot of mental health focused messages in English and Spanish. And we thought, oh my gosh, these are really relevant. We should really be spreading these. So we did a lot of work there. And then when we came back online, that's where we went fully remote. So we could recruit people, consent them, even San Francisco general patients, we could do everything remotely. So our IRB allowed us to not meet people in person, but to call them up and to help them download the phone remotely, the app on their phone remotely, help them coach them, do the consent online, and they were fully enrolled in the study remotely for the next year. And then we added back some in-person recruitment like the end of 2021. It took a while. And then the CHARM study that I just showed you, so interesting. I didn't think I would get into this. This is how always research takes you. Now the CHARM study, which is the one I just showed you across California, we offered remote on recruitment and in-person recruitment, and we've had more than 70% remote. So we changed the entire way we did the study after Diamante to add a remote option, and it's been the most successful option that we've used. And some of that has to do with patients are worried of coming in for their healthcare because of ICE raids and other things. And so the remote actually feels safe. We've had a lot of comments like that where So we call people, we have their phone numbers from their healthcare system, but then they have the option to do everything entirely remote. And so I've learned a lot about remote.
Yeah.
We call those, well, they're pragmatic clinical trials, but it's decentralized. So trying to decentralize how randomized clinical trials are run. And so we've ended up learning a lot about what that looks like, because there's a lot of really finicky stuff about how to do that. And it's been going better than I thought.
Great.
Yeah. And so the pandemic had a silver lining. Yeah. Questions?
Maybe last three questions.
Yeah. Last three.
Nick.
Yeah, hi, Brody. Thank you for the presentation. My question is more implementation science inclined.
Yeah.
Can you give a, I guess, lecture on my implementation science class? And you kind of said that you like to use the CIPR framework a lot.
Yeah.
I wanted to know, if you were to implement this, would you still use the CIPR framework? And why do you like it? Is it because it's more tailored towards digital health technology?
Yeah. So those who don't know what CFIR is, it's called Consolidated. I love it. Love the question. I didn't plant you. Consolidated Framework for Implementation Research. CFIR is sort of just a collection of a bunch of other theories and goals. And what it's looking at is, it has a patient level or an individual level, but it has all these organizational factors. So like, how do the teams communicate, and how does the communication in the healthcare system or in the environment affect the intervention? So for Diamante, because it was really just patient focused, we didn't do as much organizational types of analysis, but we did do an implementation analysis of how often we had to help patients use the system. So we tracked every time we had to call a patient, every time the phone stopped tracking their steps, every time they, so we have all of them. And what's really interesting is that 80% of patients in Diamante, if you sent them an automatic reminder of like, oh, you closed your app on your phone, they would come back into the study. So we had this like really cool automated. And then of that, we could just call only like a 30% of those and get this. So we had this really cool implementation of how do you do a trial and how do you keep people engaged in the trial, even though without holding their hand, entirely. And then in Charmed, which is a clinic level intervention, we are using an implementation framework because we really want to understand how teams can implement hypertension control. And the reason CFIR is great for that is because a lot of the things that come up for clinical care teams are they have to work as a team. Team environment. They want patients to check their blood pressure. They want information from patients at home. But as you can imagine, they have very little time to check what any patient does at home. When they go into their EHR and they look through, home readings is not top of their list. What's top of their list is the patient in front of them with an acute healthcare condition. So you have to, in order for them to care about what patients are doing at home, you actually have to change the entire workflow in the clinic to free up their time. And so CFIR works really well because that's really hard to do, right? Like, who's responsible for it, when the primary care doctor versus the pharmacist, so we have all these measures on there of like how they set up the workflow to be able to make it matter. And most of you probably don't care about clinic and behavior, but the reason I'll tell you why it's important is that if you ask patients to do physical activity or you ask them to do blood pressure at home, one of the number one things they say in a qualitative interview is, well, is my doctor going to see it? And it matters to them, right? It really matters to them. Is their doctor going to know? Does their doctor use the data? So if you want that to be true in your study, like, it's hard work, but you should be studying and thinking about how to help doctors be able to, it's not the only person in the world who matters, but it's like that trusting relationship that's going to get them engaged. And if that's one of the hooks, it sort of has pushed me into saying, how can I help doctors? Because that's what helps the patients want to do it. So that's my spiel. One more question?
I think, Andrea, next question.
Yeah, I had a couple of questions. I have more than that.
Brief.
Really quick. I was curious, did you collect information on work status and type of work being done? And if so, how did you handle that? Because I'm wondering, just based on the pandemic situation where a lot of people, based on their professions, got dropped from work, et cetera. And then my second question is, I saw the message on the right, one of the adaptive messages, I think. It stood out to me because it stated what it was framed as, what others may think of you. And I was wondering why you went about it that way. What type of discussions you have with your team.
You guys, I love all your questions. Work status, we did collect work status, but just in like full-time, part-time, retired, unemployed kind of. We did a lot of qualitative interviews about how their experiences during the pandemic were, and many people did lose their jobs. We've always wanted to write a paper about that, but haven't ever gotten our act together. But it wasn't a primary because it was starting with San Francisco General patients, a lot of those patients are on disability, either are lower income, like there's a lot of reasons why the patients at San Francisco General have a different work status than many other populations. So we didn't look at that as a predictor, but we did collect it, if that is answering your first question. And then your second question about, it's so interesting. One of the main things that came up in our design was the fact, sort of what I was saying about the doctor comment, is a lot of patients really wanted messages that were talking about their family or their loved ones. So they were like, I want messages that say, do physical activity for someone else. So that's how we ended up on that thread, is we added a bunch of messages to the bank about others. And so it's in the motivational category of like emotions and how they thought about it, but it was one of the main things that they changed within our message bank. Yeah.
I know it's one, but we had one more question from Raina.
Oh yeah.
Oh, thank you. I actually had a bunch of questions, but I will stick with one.
Yeah.
One question that I had was just curious if you could talk a little bit more about like managing the public, academic and private partnerships in the digital health space. Like we interact sometimes with researchers in the like food industry, and sometimes we're interested in similar questions, but we just have completely different, institutional constraints. And so if you could tell us about the partnership and how much flexibility you had in design. And kind of alluded to that. But,
one of those links at the paper about that. And I'd love to talk to you about it because we try to reflect on what we did differently to work with companies. The main thing that we always did was we always talked about scientific integrity up front. And we always talked about things that we would and wouldn't do. So that was sort of central to how we approached it. But from then on, we tried to be really flexible about, we really worked on things that they want, that the questions really came from them, if that makes sense, rather than it was less about, Solve is less about our questions. With a company, it's more about companies coming to us and us using our academic knowledge, is how I would say it. And then within that, though, we have a whole scientific integrity type of, if that's what you're getting at, to make sure that we're aligned. And there are many times where we have conversations and we're not aligned, but it's almost like a mission statement or a true north. We established that really early on because that allowed us to sort of guide how we had conversations with companies. And we haven't done like huge amounts of work, don't get that wrong, but I think the idea of it is something that I do really want to keep working on. I ended up doing a sabbatical at Google. So then So I was at Google for a year before I came here. And so I've just been thinking about the private sector a lot. And that is the reason I brought it up is because I think we should talk about it more. I think there are ways to partner better. I think we can stay true while also, you know what I mean? But sometimes it's seen as like, the Venn diagram doesn't overlap. And I think there are ways to make it overlap, but you have to know where you're coming from first, or otherwise, you just get off track from the very beginning, which I think is what you get off track really, really quickly from their side or our side, depending on how it goes. Yeah. I could talk about that all day. Apparently this is really fun. It means that you guys are my kind of people. I'm so glad. Thank you for inviting me. It's really fun.
Thank you so much. Let's give Dr. Lyles a round of applause.
Thank you.